Welcome to AETCM, the emergency medicine channel. Today we are going to discuss a case which was already discussed about a dengue fever case which was admitted to our ICU for further management. Shall you begin, sir?
Yes.
So, as we have already discussed, this is a dengue fever case which was admitted to our ICU. The dengue fever case is dengue which which had some complication, and later on the patient went into dengue shock syndrome. And on the initial assessment, primary survey, everything was done, and other than that on primary survey he was having a little tachypnea, respirator of 25. All other systems were initially normal, and on the adjuncts to the primary survey, we had done a USG abdomen which was showing hepatomegaly and splenomegaly, and other things like bilateral kidney was showing raised echogenicity with maintained CMD. So.
What is this CMD?
Corticomedullary difference.
What is the importance of that?
So differentiate between acute and chronic.
In CMD, if it is a cortical medullary differentiation is lost, means it's mostly a chronic kidney disease.
So, and the ECG was also normal. Initial VBG was also VBG was showing some initial changes like lactate of 2.6 and create of 1.6. So we have already discussed about the same, sir. And regarding the further thing, he was a non CAD patient, status for CABG, and non-case of type 2 diabetes mellitus. And he was on oral OHS and antiplatelets. So on admission, after admission, he came with the complaints of low-grade fever, chills and rigor, and along with his back pain, dry cough, headache, and initial lab investigation was showing thrombocytopenia, elevated inflammatory markers, and dengue announcement was positive.
What are the inflammatory markers?
CRP, then
ESR,
ferritin.
Okay, these are the positive inflammatory markers. What are the negative inflammatory markers? Positive means when it increases, inflammation increases. In some lab parameters, when it decreases, that shows severe inflammation. What is it?
Lymphocyte.
Albumin. Lymphopenia is one condition which can indicate severe sepsis. Okay, albumin level. That is one of the most important negative inflammatory markers. That means when the albumin levels are acutely very low, that indicates severe inflammation. That may be the loss of albumin to the third spaces, including from the intravascular compartment to extravascular compartment through vascular leak. So albumin is a very important negative inflammatory marker in most of the sepsis conditions.
So and dengue NS1 was positive from when we checked in our hospital. So initially his platelet count was 1,05,000, and during the course of stay in our hospital, it was showing a downtrending sequence. And initial liver enzymes were also elevated. Like initial SGOT-PT was 144 and PT was 125. On during the course of stay in the hospital, it initially reached to 615 and 333, and later on it reached to 5,900 and 2,500 OT and PT. And also his platelet count also was in a dropping state. Initial 1,05,000, then it reached to 45,000, then 20,000 and 10,000. And he was also having a bleeding manifestation like hemoptysis, then later on hematuria, and hematemesis was also there. So patient was for the same, we had started with a normal initial management was with patient was also showing inflammatory markers, and while chest was showing little crabs were also there. So injection antibiotic was also started along with IV hydration, and when patient was had bleeding manifestation, we also transfusion with platelet transfusion was also started. Then later on his BP also began to drop. Like he was having hypotension, and his cardiac enzymes were also showing a rise. Cardiac enzymes were also raised. So he was started on O2 support and platelet transfusion, and IV steroids was also given. So on subsequent days, we on as the liver functions OTPT were elevated, he was started on like N-acetyl 16 infusion was also started, and on 5th day of admission he began to have altered sensorium. So at that point of time, he altered sensorium, and also his blood investigation.
What all differential diagnosis you suspect when somebody is having this picture with altered sensorium?
ICB.
Okay. The most important thing we have to rule out is the ICP. That is because his platelet is very low, and whatever platelet is having, he can have defective platelet production. Okay, so that also will be there. So IC bleed should be ruled out. The other condition,
Hepatic encephalopathy.
hepatic encephalopathy is next. Okay,
Then as a dengue shock syndrome, patient be restless with
okay.
low platelet count.
Sepsis induced
Sepsis.
toxic encephalopathy.
Toxic encephalopathy.
Okay, hepatic encephalopathy, toxic encephalopathy, and IC bleed. These are the common things which we can come across in this type of patient.
And on 5th day of admission, he began to have altered sensorium. Along with it, he was showing elevated ferritin levels, high lactate, and bicytopenia.
What is the ferritin level?
So initially, his ferritin level was 2000, then 9000, then 14,000, and later on it reached up to 19,000. 19,000 was
So very high ferritin always indicates some severe inflammation like macrophage activation. But suppose the patient comes with severe fever, rashes all over the body, ferritin is very high. What is your diagnosis? High degree fever, rashes all over the body, which appears only during fever, high ferritin level. What is your differential diagnosis? The adult onset Still's disease. Okay. They have same picture like your multi-organ dysfunction. Renal, liver enzymes elevated, kidney may be elevated, creatinine may be elevated, but they have typical high degree fever. During the fever episode, they have that rashes all over the body. Then once the fever subsides, the rashes will disappear. Their ferritin level also will be very high. Okay.
So other than that, so at that point of time he was transfused with FFP, PRBC, as his HB was also dropping. His HB dropped to 7.02 was his HB, and one time PRBC was also transfused. And FFP was transfused, and
What is the INR?
INR, initial INR was 1.2, it climbed to 1.53 with an APTT of 60.60. And
What is the
fibrinogen level was also in the near normal. It's 272 was the fibrinogen.
Okay. Same like that, if the fibrinogen levels are also a marker of inflammation. So high fibrinogen level always indicates inflammation, but a low fibrinogen level indicates coagulopathy.
His LDL value was also elevated, 5,600.
What is the importance of LDH in this type of
Liver injury.
LDH.
Hemolysis.
Hemolysis. So active hemolysis can increase the LDH. Okay. When some types of lymphomas also or blood cancers, leukemias also, LDH will be very high. But this type of sepsis cases, if LDH is high, you have to always think about hemolysis.
His D-dimer value was 1.34, and we also sent for one procalcitone. So procalcitone came to 1.33.
Okay.
So at this point of time, as the patient was having bicytopenia with elevated ferritin levels, fever, and altered sensorium, we had a suspicion that the patient might be going into an HLS.
What is the cholesterol level?
So we sent for the cholesterol. FLP was sent, in which triglyceride was 208.
It's only slightly elevated. One of the criteria for that is high triglycerides.
So yes, a suspicion of HLS was made, and for HLS to be made, we have some criteria for if it is HLS or not. So the thing is that the patient should have 5 of the total 9 components of HLS. It includes fever, splenomegaly, bicytopenia, along with hypertriglyceridemia or hypofibrinogenemia, then hemophagocytosis, then ferritin level should be elevated. adequately, it should be more than 3000, but in some textbook it is written like greater than 500 will be more than enough. Then the other test like low NGS killer cell should be low, and also elevated CD25 and CXCL9 should be elevated. If 5 of these 9 are completed, then we can say that the patient is in HLH. Along with the patient should have some infectious etiology to say it's as HLH with the and mostly HLH occurs in adults in case of some viral infections.
The HLH can be due to primary HLH is known, but secondary can be due to infections, malignancies, and rheumatological disorders. So many other conditions also it can be positive. Here maybe the dengue might have triggered the macrophage activation. Okay, what is this macrophage?
So macrophages are the ones which help in our immune system for
they try to kill the bacteria, virus,
viruses.
fungus. But unfortunately, this dysregulated macrophages they can kill our own cells. Okay, that is happening in macrophage activation syndrome.
So here the increased CD8 and activated macrophages will cause increased interferon gamma release and other cytokines, which will cause autoimmune immune related inflammation and further manifestations in our body. So as it's an autoimmune like condition, so main our management will be to regulate the immune system of our body. So initially itself we have started with the DEXA. We gave a high dose of dexamethasone initially.
Pulse
dose was
what is the dose of dexamethasone as a pulse therapy?
40
mg. So if it is equivalent to 1000 milligram of methylprednisolone. 40 milligram dexamethasone is equivalent to that. Okay, it's very cheap also.
So we pulse him with 40 mg dexamethasone, and other than that, he was fulfilling the criteria for the HLH at that point of time. So during the course of stay in the hospital, his respiratory distress increased, and also his hypertension was on the same level. He was not improving, and his on BBG his lactate level increased. Lactate level reached up to 18.
Okay.
And we started him on IV dobutamine infusion was also started.
Okay. What is the advantage of dobutamine in lactic acidosis? Why we start dobutamine?
Stroke volume.
See, dobutamine is not a good drug in hypotension. You have to start noradrenaline and increase the BP. Then then only once the BP reaches more than 100 millimeter of mercury, you can start dobutamine. Actions of dobutamine are it produces vasodilation, especially in splenic abdomen. So that gives good circulation to the tissues. Then it reduces the lactate. Okay, the end product of anaerobic metabolism is lactate. When you are giving good circulation to internal organs, that reduces the lactate. So dobutamine is actually not doing any benefit to the patient, but the lactate, the anaerobic metabolism will change to aerobic metabolism because of good circulation to internal organs, and lactate will come down. That is in turn shown as a improvement in the patient's general condition.
Initially, already Norad was started for the patient. Okay. Then we started with the dobutamine.
Okay.
So
noradrenaline, how do it help in the internal circulation? Mostly these type of noradrenaline type of drugs, they constrict the peripheral blood vessels. They constrict the peripheral blood vessels so that more blood will go to the internal circulation. That also improves, but to get a better result, you have to add dobutamine to your noradrenaline.
And later on, the patient had a severe respiratory distress on our 6th day of admission, and his PCO2 retention was severe acidosis occurred, and we intubated the patient, sir. After intubation, so right at that point of time, a diagnosis of HLS was made, and we have arranged for cytosol therapy.
What is the cytosol therapy?
So cytosol therapy is the in cytokine storm can occur. Like in HLS, there will be large amount of cytokine release, which will cause cytokine storm. So for to remove the cytokines from, we can start with cytosol therapy, where this cytokines will be removed from the body.
It is like a filter.
Filter.
So when the blood is going through that cartridge, the cytokines will be adsorbed to the membrane, and that will be removed. Only good blood will go back to the circulation. Okay. So ideally, we have to check the blood sample before and after the cytosol therapy. So before we take a sample and see what are the interleukins there, but that is very costly. That test is very costly, and after that, how it is improving, then only you can get a good result. But unfortunately, the tests are not available everywhere, and it is very costly. So we just do the cytosol so that some amount of toxins will be removed.
So ideally for the HLH patient, along with the routine investigation, we'll have to do bone marrow for to look for any hemophagocytosis. Then LP should be done. Then MRI, and also look for the interleukin receptor like CD25, CD116. Then also we'll have to look for CXC, CL9 also we have to look for. Then flow cytometry should be also be done for looking for any NK cell or any perforin should be done. And for the treatment part, the main therapy will be like starting on steroids and also cytosol therapy. And along with this, we can start with there are new drugs which are used for the HLH, like etoposide can be used.
Etoposide is an old drug.
Then ruxolitinib can be done. Then doxorubicin, then emapulizumab can also be used.
So monoclonal antibodies are second line of drugs, or where the steroid is not responding. There you can use it. There also it is very costly and not available. So we can only, at present, we can only go with steroids and other this type of cytosol therapies. Okay. So what are the types of macrophage activations? Types.
Sir,
Types means primary. Primary is without any trigger, patient develops all these things. Secondary can be due to various reasons. Various reasons like infection. That is the most common thing. And that dengue fever is one of the most important. Dengue HLH is not explained in textbooks, but what we are seeing is multi-organ dysfunction syndrome in dengue, or most of the time comes under this category. Then malignancies, blood malignancies, lymphoma, leukemia, all these things. Then rheumatological disorders, especially
rheumatoid arthritis. Juvenile
rheumatoid arthritis. That is juvenile rheumatoid arthritis, sometimes called as Still's disease also. But adult Still's disease is different from that. It is slightly different. SLE is the most important condition where you get all these things. But it's a male patient, so SLE and all cannot be made out. But malignancy will be a strong possibility in this type of patient, because we are getting dengue positive. That doesn't mean that all these cases are dengue. Okay. We are only getting a blood test. Previous dengue infection also can show it as a dengue fever. Okay, an amnestic reaction can be done. So in this type of cases, if the patient deteriorates very fast, it is better to do, if possible, do a bone marrow and see whether any blood-borne malignancy is there or not. And that we are not able to do because patient is very sick. Okay. Thank you.